A beautiful day can end with a life-threatening storm. The symptoms of mental illness, although frightening or bizarre at times, are actually extreme forms of the natural sensory and emotional experiences of all human beings. Have you ever been walking in a busy shopping mall and thought you heard someone call your name when in fact there was no one there? In an extreme form, this could be a hallucination. Have you ever reached to the ground to pick up a coin that turned out to be a pattern on the floor? In an extreme form, this could be an illusion. Or have you ever locked your keys in the house or car? In an extreme form, this could be a sign of concentration or memory problems. Have you ever become so frightened, sad, or angry that you lost it and had an emotional outburst? Or have you ever lost your appetite or canceled plans because you just didn't feel up to it? In the extreme form, these could be symptoms of a number of psychiatric disorders. These are all common and normal sensory or emotional reactions to the world we live in. Sometimes due to a combination of genetic, physiological, and psychosocial influences, what would usually be a normal response becomes extremely maladaptive or abnormal. Dr. Tim Egan explains some of the most common mental health problems experienced by older adults.
The current criteria used to make the diagnosis of delirium is that there has to be a disturbance of consciousness, that change in thinking or perceptual disorder cannot better be explained by dementia, that the course has a relatively recent onset and tends to fluctuate throughout the course of a day, meaning that at times symptoms were more severe or less severe throughout the course of the day. And there is some evidence from a history and physical or laboratory studies that there is a specific medical condition or multiple medical conditions or substance intoxication or withdrawal that explains the symptoms. In other words, some sort of a concrete explanation for why a person would have a disturbance in consciousness that fluctuates throughout the course of a day. There are certain risk factors for developing delirium. One is advanced age. The older the person is, the less it takes to cause a confusional state or a delirium. Things like infections, electrolyte imbalances, renal disease, kidney disease, or liver disease can all be causes of delirium. Finally, any central nervous system illness can cause a delirium or place a patient at a higher risk for delirium, including dementia. And it's not at all uncommon to see dementia being complicated by delirium so that the clinical course is confusing. Recent surgery or trauma, including burns or hip fractures, are common causes of delirium in the hospital setting. And any type of alcohol or sedative hypnotic dependence or withdrawal or opioid use can result in delirium.
With experience in long-term care as the director of nursing, oftentimes when a patient experiences delirium, it's a rapid change of their behavior. And it may be an increase in anxiety or an increase in agitation, oftentimes a withdrawal or a acting out behavior. Frequently it's associated with a couple of different things. It's an environmental change. They moved, either admitted to a nursing home or moved from one wing to another, or it's a physical thing. Urinary tract infection, upper respiratory infection. So we encourage people to really look at what is going on physically and environmentally for this person prior to trying different medications to treat the mood.
It was a lady that I saw in a nursing home, and suddenly she started having hallucinations and her behavior became more bizarre. And we started looking through the charts and saw some evidence of a rise in symptoms showing that she may have had a urinary tract infection. And then once that urinary tract infection consequently became treated, it was interesting that those symptoms all went away. And we found later on through the couple of years that I tracked this individual that every time she started to have these symptoms, they would go and look and see if she did have a urinary tract infection. And as soon as they treated that urinary tract infection, those symptoms went away. The symptoms that she particularly was having were visual hallucinations. She would start seeing little men crawling about her room, little gremlins, as she would call them. And while they were kind of entertaining at times, other times it was very upsetting to be seeing those things. But again, they did go away pretty quickly once they treated the physical problem.
Obviously, the treatment of the delirium is to identify the underlying cause in those cases where it's possible and to treat it, which generally results in a reversal of the confusional state that goes along with the underlying medical condition. Sometimes it takes longer for the confusional state to clear up than it does for the medical condition that caused it to clear up. And sometimes that leads to some confusion in hospital settings or nursing home settings about whether what was presumed to be the initial cause had really caused the confusional state. Some of the other interventions that are involved in treating patients with delirium are to intervene in non-medical sorts of ways, hopefully try to keep the patient oriented, try to relieve their anxiety during times when they're feeling quite agitated, try to get them corrected in terms of their sleep-wake cycles. And then there are also times when you would want to use pharmacologic interventions, but generally only for severe discontrol or patients who are having severe bouts of agitation with their confusion. Although there are a variety of causes of dementia, the clinical evaluation and laboratory evaluation are aimed primarily at trying to define those people who may have reversible illnesses. A variety of authors in the past have discussed what they think the number of patients who actually are diagnosed as having dementia might be that would have a reversible cause for that dementia. And the most optimistic numbers I have seen have been about 15%. Probably someplace in the range of 10 or 15% of the patients are going to have a reversible cause for their ongoing dementing process. And generally speaking, that is picked up by the internist or perhaps a neurologist who has seen them either in the office or the nursing home or perhaps in the hospital. There are a regular set of studies that are ordinarily obtained in order to try and rule out reversible causes of dementia. And routinely, a complete blood count, an erythrocyte sedimentation rate, a set of serum electrolytes, some measure of kidney function, either a BUN or a creatinine, liver function studies, a B12 level, a test for tertiary neurosyphilis, a urinalysis, and an HIV are indicated in evaluating patients who have dementia. Probably most people would agree that a CT scan of the brain is indicated at least once in the course of someone who has a dementing illness, primarily with the idea that you might be looking for a condition referred to as communicating or normal pressure hydrocephalus. In that condition, there is a surgical intervention that could potentially reverse the course of the dementia. In the group of dementias, there are what are referred to as degenerative dementias. In other words, there is some ongoing degeneration of central nervous system tissue that results in the symptoms and signs of dementia. The most common of these, obviously, is Alzheimer's disease, or senile dementia, the Alzheimer's type, as it's sometimes referred to, and probably accounts for about half the patients that we see that have dementia. Probably second in its frequency would be those that are vascular causes, commonly referred to in days past as hardening of the arteries. Often you see patients who have some evidence of small vessel disease in the central nervous system who have progressive dementias. Some of those patients with vascular cause may also have degeneration of the form that you'd see in Alzheimer's disease. Some of them may not. So there are combinations in the degenerative illnesses of Alzheimer's disease, of the vascular diseases, of generalized atherosclerosis, and then some combination of those two illnesses probably account for the majority of patients that we see with dementia. The Diagnostic and Statistical Manual of the American Psychiatric Association in the 4th revision lists a variety of different diagnostic categories for depression, the first of which is a bipolar disorder. And in general terms, a bipolar disorders are that group of conditions that are commonly referred to as manic depressive illness. The other groups are referred to primarily as the depressive disorders, and they vary in severity from a less severe diagnosis like dysthymic disorder through a depressive disorders and through depressive disorders with psychotic features. Just to review the diagnostic criteria for the diagnosis of major depressive episode, The patient has to have 5 or more out of a list of symptoms, and the symptoms have to basically be present for a period of 2 weeks or longer and be persistent in nature. The patient has to have either depressed mood or inability to experience pleasure, accompanied by a weight loss or weight gain with an appetite increase or decrease, either insomnia, most typically waking up in the middle of the night and being unable to go to sleep, or hypersomnia, psychomotor retardation or agitation, fatigue, feelings of worthlessness or guilt, poor concentration and indecisiveness, or thoughts of death and suicidal thinking. There are a variety of medical conditions that can look like a major depressive episode, and of course in the elderly population with all their physical problems, one has to consider all of these. This is really the area where the psychiatrist and his evaluation become more important. Certain medications that you may encounter in the nursing home population can also increase the risk for developing a depression or depressive-like illness in elderly patients. There are antihypertensive and cardiovascular medications. The most common examples of medications that were used to treat blood pressure problems in the past that result in depressions were reserpine and alpha-methyl-dopa, or Aldamet. Those are older generation antihypertensive medications. We don't see them used quite so much anymore, and are probably less of a risk. Although in nursing home populations with your older patients, you will see some patients that have been on those medications for a number of years. Any medication that is active in the central nervous system can also cause a depressive-like picture. The use of opiates, the use of L-Dopa, or Sinemet in the treatment of Parkinson's disease. One of the ways that can cause difficulties is to cause depressive-like syndrome or a psychotic syndrome. Drugs of abuse, benzodiazepines, barbiturates, antipsychotic medications can all paint a picture in elderly patients that looks quite a bit like depression. There are a lot of good reasons to treat depression above and beyond the fact that it causes a great deal of suffering. Some of those reasons are that untreated patients with major depressive illness will complete a suicide about 15% of the time. If they're over 55 years of age, then their death rates are 4 times higher than the general population. There are also a variety of disorders that can occur accompanying depressive illness, including panic disorder, substance abuse, obsessive-compulsive personality, and eating disorders. There are no specific laboratory findings, and the illness of depression seems to occur twice as often in women as it does in men. One of the questions that always comes up is how do you assess suicide risk in patients, and in particular in the elderly patients. The single highest risk factor for suicide is the diagnosis of a major depressive episode. In other words, if patients meet those diagnostic criteria for a depression, those are the patients that are at the highest risk for completing a suicide. A history of prior attempts also increases the risk. If patients have severe pain and debilitation, they're at increased risk for completed suicide. Confusional states in hospitalized patients or in nursing home patients can also result in a higher risk for suicide. In general, I think it's safe to say that women have more suicide attempts and males have more completions, although when you talk about general populations, that weight doesn't help you very much when it comes down to assessing the individual patient.
One of the things about suicide in older adults that comes to my mind is that we have to differentiate between active suicide and passive suicide. Very often it appears that the numbers of suicidalness in older adults is underestimated because there's a whole host of people who passively allow themselves to die or commit suicide. Examples of passive suicide include deliberately not taking medications at the right time, continuing to engage in some type of an injurious behavior despite the fact that that behavior results in a person having quite a dramatically shortened lifestyle. Examples are eating terribly inappropriately, smoking terribly inappropriately at a time when they're supposed to be recovering from a lung problem, generally being careless in things that could be very devastating, such as engaging behaviors that might increase the likelihood of their falling, and their falling could have a very dramatic impact on their health status.
Dementia has a more gradual onset, such as you see in your patients with Alzheimer's disease. The course is longer than 1 month. It's progressive, and it's not necessarily associated with decreased alertness. And the opposite, of course, is not true in delirium. Depression is sometimes added to the differential diagnosis and generally presents with a clear sensorium. People know where they are, they know what the date is, their memory and orientation are all intact, but they can appear to be demented or very forgetful. Personality disorders are generally thought of as being long-term, ingrained maladaptive patterns of behavior that cause people to come into conflict with others or to be unable or less able to function in social and occupational settings. In the elderly population, you'll generally find personality disorders as being exhibited through, quotes, troublesome, end quotes, behavior. Often stubbornness, refusal to participate, manipulative types of behavior, a whole variety of maladaptive types of things come into play in the nursing home setting that are not particularly responsive to medication management. They can at times be responsive to nursing interventions or behavioral types of interventions if the situation is studied closely.
In the long-term care setting, I think it's very important to be careful about the usage of terms like personality disorder or mental illness or depression, delirium, or dementia. We're looking at an individual here who needs to be treated as an individual, and those things need to be sorted out to make sure that we're dealing with the correct problem.
Examination of mental hospital records indicate that American Indians are much more likely to be hospitalized with the diagnosis of a personality disorder than the general population. In analyzing these data, what I believe is going on is actually this diagnosis is given because they're angry people and have very good reason to be angry in a culture that is not supportive of their lifestyle, their culture, their belief system, and so forth, and that the diagnosis is given when people are acting out this kind of anger. I think that it's real important that we look at anger as being, in many cases, a realistic and appropriate response to some of the experiences that people have.
We can't all avoid these people that have difficult personalities because someone does need to go in and make sure that their cares are being taken care of and that they're getting at least a little bit of social interaction with some other people that live there.
We had a resident here that she was very, very rude and very combative, and for some reason she liked me. I don't know why. And her and I got to be real good friends, and I think that was the best thing because that taught me that, you know, don't judge people by what they look like or what other people say. Good. She was great.
This program has emphasized the concept that psychiatric symptoms are simply extreme forms of naturally occurring human sensory and emotional experiences. The most common mental health problems experienced by older adults, delirium, dementia, and depression, have been discussed in relation to the importance and complexities of diagnosing these disorders as they occur separately or in any combination. The challenges and opportunities regarding individuals with personality disorders have also been highlighted.